This meeting is being recorded.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Allen will be representing Dr. Mitchell Katz in a voting capacity, and she's coming in the room right now. So first, I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on December 5th, 2022. I will go around the room. Dr. Pagan?
Yes.
Dr. Allen?
Yes.
Sally Hernandez Pinheiro?
Yes.
Dr. Martone?
Yes.
And Ms. Lowe?
Yes.
And I vote yes, so the motion is adopted. Next, we have an action item for consideration. Mr. Siegler, could you please read the resolution into the record and then start with the presentation?
Absolutely. Great to see you all. This resolution is authorizing the New York City Health and Hospitals Corporation, the system, to contract with Ambulance Holdings, LLC, the contractor, for a single vendor patient transportation system for a term of 3 years with 2 one-year options exercisable only by the system for amount not to exceed $94,762,581. We're excited to make this presentation to you today after a really impressive multidisciplinary process of going through this, and our outstanding leader for transportation operations, Caitlin Prieskorn, will take you through the presentation.
Thank you. So we're here today to share a background on our single vendor contract that we started in 2019 and then ask for approval for a new contract for ambulance and ambulette transportation for the system. So we built a single transportation system in 2019. We began the ability to better transfer patients within our facilities, growing the transfer volume by 26%, leading to an estimated $78 million of additional revenue. Our single vendor was also able to substantially help us during COVID, garnering about 2,000 interfacility level loading transfers. However, with the result of COVID and a statewide, national-wide staffing shortage for EMTs and paramedics, we found the performance of this particular vendor degraded, and thus the need for us to revisit the contract and open up for RFP, building on the lessons that we've learned from the original contract and aligning our contractual incentives with a new vendor to be able to drive performance forward, continue the gains that we've made on interfacility transfers, and optimize length of stay by consistency around discharge timeliness. So we released the new transportation RFP in August, and this has 3 separate scopes of work. So one of the things that we've learned through the prior or current contract is for us to have the ability to consistently keep critical interfacility transfers within the system, we require quick timeliness of ambulances. And so the first scope of work is new to health and hospitals. This allows us to have dedicated ALS or advanced life support ambulances strategically stationed around our geographic footprint, designed to be able to leverage in those instances in which we have a critical interfacility transfer. The second scope of work contains all of our normal ambulance and ambulette transportation. So this includes non-critical transfers, and it also includes any discharge transportation requests. And the final scope of work is for transfer center services. So this is the medical communication center that our providers utilize in order to move patients from one facility to the next. So the RFP criteria that we used includes 5 years in business in New York City providing similar services, the capacity to provide at least 50,000 annual transports, and over 10 million in annual gross revenue. The selection committee evaluated based on cost, the network and accountability plan, the data and technology that this particular vendor would bring to the table, and their experience. The evaluation committee was comprised of clinical and operational and financial leaders, both central office and at a number of H&H facilities. So the timeline for this procurement, we released the RFP at the beginning of August. On August 23rd, we had a pre-proposal conference. 8 vendors attended. Proposals were due on October 5th. We received 4 proposals. At the end of October, proposers gave a series of WebEx proposal solutions. At that point, we determined that we would best like to meet with these vendors in person. And so at the end of November, the evaluation committee debriefed with these vendors in person and ultimately made their decision on December 7th, as ambulance was the highest rated proposer in each scope of work. So when this was originally set out to RFP, we looked at our current vendors model for identifying minority and women-owned subcontracting opportunities. So in the ambulance scope of work, there is one vendor that currently provides services within New York City. In the ambulance scope of work, there are 2 vendors that provide these services. Unfortunately, both of these, or all 3 of these vendors, did not meet the minimum criteria for responding to the RFP. So they could operate as subcontractors, but unfortunately would not be able to operate as contractors. Now, ambulance, in their plan, they operate with a different business model. They do not utilize subcontractors for ambulance and ambulance services. They anticipate providing all of those services themselves. Now, they do use contracted staffing services. So our vendor diversity team met with ambulance, who has done a substantial volume of work with health and hospitals in the T2 areas, to identify that on staffing and PPE and supplies, there is additional opportunity for ambulance to subcontract with minority or women-owned businesses. And so as you can see at the bottom of the page, ambulance has proposed contracting with these 2 vendors, and this represents 10% of the total contract value. Ambulance has also agreed to continue to explore opportunities with us to grow that percentage over the contract lifespan. And so our work with ambulance, we will finalize the implementation plan, but one of the nice pieces with this new vendor is their unique model. So they will be doing all of the services for the entire system themselves, and they give us the ability to leverage on-demand and dedicated resources both in the ALS, advanced life support sphere, as well as the basic life support model and the ambulette. So this is a change for our operations, where we're currently requesting a resource, and whatever resource is closest, they might arrive, but it might be 30 minutes, it might be 60 minutes. What ambulance has committed to do is providing a number of resources at each of our sites to be dedicated for discharges and allow our sites to schedule discharges, thereby increasing the reliability and decreasing the timeliness that we can expect to see for discharges coming out of those sites. The other piece that they are offering to us is ambulances that will include our logo. So they will be co-branding a number of ambulances, the ones that will be dedicated at our sites, and they will reflect health and hospitals and ambulance. And so we look forward to working together over the next several months, beginning with our acute care facilities, transitioning them from our current contractor over to ambulance, building at the clinical model for our dedicated critical transport resources with our clinical leaders around the system throughout this time period, and then expanding to post-acute care facilities and the adult day program later on this spring and into early summer.
Happy to take your questions, and thank you for listening.
Just 3 questions. One, could you help me understand the difference in the model of how it operated under the prior vendor and under ambulance? I got a little confused on.
So in the current model, we have a number of resources that are pooled resources. This means our request as a system, as well as any other system that the vendor works with, are all competing for the same resources. This new model dedicates resources to both our system and to our facility. So even if the vendor is working with a different system, our resources are our own. And so that other system would not be able to leverage those resources.
Right. And so the resources, I guess there's some analytical work done to assess what the appropriate level of resources is. And then do you still have the ability to access more if the demand level is beyond what you anticipated?
Correct. So we are going through a series of conversations currently looking at our current demand, our volume of transports, the time of day that these transports occur. We're matching that with the number of resources that would be needed. That comes to our dedicated model. Now, Ambulance also offers resources that are pooled in which we could leverage if we have a request exceeding that volume of dedicated resources that we have available to us.
And just to follow on that, Sally, though, what if the estimate for what is dedicated is too high? Are we going to be paying for unused?
So that's a great question. What we'll build into the contract is that ability to look at our dedicated resource hours, and if there is a high idle rate, we can reduce that number of hours that we've requested dedicated resources. And so that would be an expectation that we would have to minimize the inefficiencies that could be experienced under that model.
Under your, just two more quick questions. Under your old model, were there things that we learned from the old model that obviously the pooled model didn't work as well as this dedicated model that you're going to have? Did we learn anything else in how the relationship worked and what we thought we needed to do differently? I guess the penalties maybe is one thing.
Yes, the penalties are a big thing. It aligns the contractual obligations with the needs of the system. So if the vendor performs well, they have incentives to do so. And if unfortunately they do not, we have the ability to disincentivize them. We've also learned that the technology that our staff use to both monitor and make requests is better facilitated directly through the EMR, through Epic. And so this vendor has the ability to do that, and that streamlines the transportation request process for our facility staff, and it also enables our units to be able to see on a map, here's where the resource is, and thereby have a sense, how quickly are they going to be arriving to the facility? All right, they're on their way, let's get that patient ready to go. That minimizes the at-scene time that the ambulance or ambulette crew is waiting for that patient discharge to occur.
And just my last question is a sentence on page 3. It talks about includes requirements for EMR transportation request integration to minimize duplicate documentation, maximize insurance capture. What is that about? What does that mean?
Right, so having the integration with EMR will allow our facility staff to pull the demographic information from the patient's chart automatically.
Okay.
And not duplicate the insurance information. So in the current state, our facility staff are typing in the demographic information, they're retyping the insurance information, and there are opportunities to refine that process and ensure that it happens consistently. And so this integration would ensure that it happens automatically. The demographic and the insurance information flows through during the request.
Right. Okay, thank you.
I have a question.
Oh, Barbara.
I know we have a lot of activity on the road every night, every day of competing entities. How do we work out the labor issues, if there were any?
The labor issue, I mean, I think overall, you're right to point out that the staffing of these vehicles was the number one challenge for our current vendor and will be the number one challenge for this vendor. It's a critical period for this workforce around the whole country. And the scale of the sign-on bonuses for people, the level of pay for EMTs, it's just dramatically changed versus 3 years ago. So ambulance, I think, as a model and as a employer, is an attractive one. But they're going to be making a big push to staff up for this, and monitoring how that proceeds and how successful they are at that will be, I'd say, one of the 2 or 3 things that determines how successful this contract is. On the kind of labor front, competing between vendors, as I understand it, people definitely jump between vendors based on whose package is more attractive. So we have to work with them on that. I think one of the attractive things for us about Ambulance, they've done great work for us through the T2 program. Their founder and CEOs, I believe parents both worked at Bellevue. I think they view this as a commitment to the city and to our system in a profound way. Certainly, there's financial interest for them in this, but our experience with them has been a kind of really deep commitment to work with us. So we think there will be open lines of communication and a lot of good work with them to make these kind of critical staffing investments and other things happen to be successful here, because it's a big step. Did I answer the question? Yeah.
The financing of the trucks. They're not trucks, I know, they're ambulances. But some of them may have to look like a truck too. Are we buying those, or are ambulance factoring that in the contract?
Ambulance is factoring it in.
Okay.
And we've been impressed to see the age of the trucks that they require for their fleet, how quickly they refresh them. That's an important thing for us. And they will be financing it themselves.
Training. Sorry, guys, I have to,
Oh.
because it's a big one with the dosage of many different drugs we give in the field. I would hope that there's good alignment with our standards. That's all.
Yes, absolutely. I think they're responsible for their own training, but I think a key area that we want to explore and that has been important to us is joint performance improvement on what this is a kind of inartful term, but it's what they use. It's called package time, right? How quickly, when a patient is ready to go and the ambulance arrives, how quickly can our 2 teams work together to transfer that patient from the bed to the ambulance? The speed of that in minutes means a great deal, and so having a partner that can really work with you on that and shares joint training standards, and then we can build together with.
Will we lead that partially because there are certain drugs that became an issue over the last 3-4 years? Who's administering? What's this training, etc. So will we lead the training of their staff? Or?
I don't believe we will lead the training of their staff overall
work it out somehow.
for these kind of package time interchange interactions. I think we'll have to discuss who is kind of point on the training, but for their kind of onboarding of staff, I believe that is their separate responsibility.
Thank you so much.
Of course.
Sorry, just a follow-up question. You talked about the performance of our last vendor degrading at some point, and this is a big contract for a critical service, and our ability to pivot on these things is limited just because of how integrated it is in what we do. So I don't know how timely we were able to intervene when the service began to degrade under our prior vendor, but have we learned something about how to monitor and address
Absolutely.
those kind of issues?
Right, so the first piece is to build out the contract incentive and make sure that those are in line so that they keep their staffing levels to where we need to be. The second is transparency on data and their ability to have resources around the system. So we will be tracking very closely their on-time compliance. We'll be continuing to monitor and evaluate what happens in situations in which their on-time compliance wasn't met. Is there a systemic issue? Is it a one-off? And how do we address those systemic issues with performance improvement projects led jointly by our team and their leadership team, and potentially the facility that may be involved as well?
And I'll just add to that. I think the key learnings from that process are reflected in the scope of work in the RFP, right? So we, with our current vendor, we pushed them and invested more within our allotted amount from the board to have them dedicate resources in strategic locations between key facilities. So we would place a vehicle, a dedicated vehicle, either kind of at Coney Island Hospital or between Kings and Coney, a separate vehicle, say, right near the Triborough Bridge, because it's central to a few of our hospitals. And that model had some success, but our ability to double down on it and to put as much dedicated resources as we want in this contract was not there with the vendor. Similarly, on the data transparency side, Caitlin and team did a tremendous job tracking in daily, weekly meetings with this vendor the back-end data infrastructure for the current vendor and their 6 or 7 subcontractors is just not as unified, integrated, and frankly high quality as the ambulance data systems. So those two things are very real and tangible changes and investments that we used in designing the RFP and then rating this vendor.
Thank you. Michelle, you have a question?
Yeah, I just had two questions and a comment. The first is the comment to thank you and Caitlin for being available over the weekend while we were planning to support the voluntary hospitals that were going to go on strike. So I want to say thank you. The question, which I think you answered, is looking at the targeted time frame of the rollout. We have Elmhurst, I think, then the Brooklyn hospitals, and then the Manhattan hospitals, and then I guess Bronx is last. Are we targeting the level 1 trauma sites, or are we targeting all of our facilities? I see the post-acutes down here as well.
So all facilities are being targeted for ease of vendor rollout. It's easier for the vendor to go borough by borough. But of course, if we feel that we need to scale up differently as a result of a strike or other circumstances, this vendor has been more than happy to modify the implementation plan and adjust the rollout dates based on the system's needs.
And then kind of a follow-up to Sally's questions in terms of metrics. I think we lose out in trying to retain our patients within H&H because some voluntary hospital will show up quicker. Are there benchmarks that we can actually follow? Are there benchmarks that we can compete with the voluntary ambulances?
Certainly the SLAs that we have in our current contract and that we're exploring with the new one, we view as market standard, right? Within 20-minute arrival for any emergency transport, over 85% of the time has been the standard SLA. Again, some voluntary hospitals have traditionally kind of parked ambulances at our facilities and just waited, right? And so that certainly reduces the average from a trip time to less than that. So we have struggled to beat that with our current vendor and the current model and the constraints of the system. That is certainly something we look at, and Caitlin and we have as you saw from the work this weekend, we know the transportation teams at different private facilities and have looked at it and tried to line ourselves up with market. But that does seem like a metric that we measure ourselves against and will continue to push on.
Are there incentives built into this if that at a certain percentage of time they are at or below the benchmark, they get an incentive? Or?
That will be key. It will be part of this contract. We can't formally negotiate and finalize the contract until we have hopefully board approval. But the vendor certainly knows that is the direction we're headed and is a fundamental part of what we will require from this contract.
Thanks, Matt. Thanks, Caitlin.
Jose, did you?
No questions.
No questions. This is great, and I know we've had historical conversations about how transformative the whole transportation effort has been. So I think it's terrific, and you talked about it a little bit. I just want to ask because I feel like I have to. So the contract value, if I'm understanding correctly, before was $22 million roughly for the 5 years. Is that, or was this just for the extension period, the increase?
So the $22 million was for the 4 years for the prior vendor contract.
4 years. Okay, so it's a little bit less because now we're approving $94 million for the 5 years.
Right, our spend under the prior vendor was about 5.5 million annually. And so with the additional scopes of work and the investments that we're looking to make and having those resources available,
Right.
dedicated, that's why,
It's considerably different.
Yes.
Yeah. And I think, we demonstrated how important that was in terms of the value that it helped us capture and retain, and so hopefully that will continue. And so just to be clear, and I think you mentioned this, the dedicated event, the 3 scopes, the first one just did not exist.
Correct.
Other than, Matt, what you just said, you tried to target a few instances to develop that. So it sounds like we learned a lot, and the way you're designing the contract will make a lot of sense in terms of incentives and penalties, and so that's great. I didn't hear what you said. What is the transfer center services?
The transfer center is the medical communication center, effectively the call center in which our physicians utilize in order to transfer a patient from one facility to the next.
Okay.
So the transfer center follows a series of protocols to be able to connect the referring provider with the appropriate team at the destination facility. And
Right.
so they can make the physician connection, they work with bed assignment teams at the destination, and then facilitate transportation with our vendor.
Okay. And we didn't have that in the contract before, right?
Correct.
This is new also, and how was that performed before?
We had a separate vendor doing
Oh,
it.
the
We had
separate.
a different separate vendor, so we offered that as a separate scope of work.
I see.
Ambulance applied to do it, and we thought the integration of all of them together was a better result for us. It's
Okay.
still as integrated as it is in the electronic health record. There's still as a value of doctor to doctor, nurse to nurse. Which bed is this patient going to? How far away are they? What do they need? And so that, making sure people aren't waiting on hold and connecting them directly is still something we want to work on, and ambulance will help us with.
Right.
We may bring it in-house at some point. It's a function that a lot of systems do themselves.
I wondered if it was in-house before, but you had a separate vendor.
We had a separate vendor, and it's just a question of how we want to work that. But ambulance is open to partnering with us closely, and I think we'll build something good with them.
Okay, great. All right.
One last one.
Sure.
Will they be able to give us some scenarios on how well they're doing, like through our PI? The medical management is very critical at their level. I was just wondering if we have that role as well.
I think it is an excellent one. I don't think we will build into the contract certainly reporting on clinical outcomes things. We track that ourselves.
Okay.
But bring it to the QAPI committee is a great idea. I think if they're open to that, I'm sure we'd be happy to bring that to them. Thank you for the suggestion.
Great. If there are no other questions, I would like a motion to accept the resolution. Okay, great. And I'll poll each member. Jose?
Yes.
Dr. Allen?
Yes.
Sally?
Yes.
Dr. Martone? And Barbara?
Yes.
Great. And I also vote yes, so the resolution is approved to go forward to the board in a couple weeks. Thank you.
Thank you.
So next on the agenda, we have a brief financial update. We just had an extensive one in December, so a little bit more abbreviated this month, but I think James is going to start us off.
Sure.
Thank you.
Yes, it is brief, as you noted, but we just did want to come back and talk about some of the important things we have now and looking forward to 2023. So in terms of our cash position, we ended December just shy of $450 million. As we've talked about before, December is historically a bit of a low month for us, so it's encouraging that we were able to still be stable around our 20 days cash on hand, where we start to get a little worried, but we still, do have the cash there. So that was a good way to end the calendar year. And looking forward to January, we're hoping that we'll tick up a bit, as we generally do in January, to about $600 million or 26 days cash on hand. Our hope really is, and we'll get into it a little bit on the next slide, but that we'll receive at least one of our UPL payments from prior years, the 2021 outpatient, as well as hopefully the DISH payment that we generally receive in January. So with that, that would put us in a strong position, going into February. And, with everything continuing to go on with COVID, with our liability city, we're just going to continue to work with them, depending on what does come in. to ensure that we're good, going into the rest of the fiscal year.
And are we looking around the same level right now? 450 million is currently, we're what, 2 weeks in?
Like as of today,
Yeah.
we're around $400 million today.
Declining, so we're counting on that money coming in.
Yes.
Yes, okay, great.
We'll tick up a little bit later in the week, but yeah, about $400 million today. So if there's no other questions, just looking ahead to 2023, we kind of wanted to just give a view of the state and federal risks that we have expecting, as well as some opportunities that we're hoping we'll be able to bring across the finish line. So the first really is related to a lot of payments we've been talking about for a long time. So the first would be the successful ongoing implementation of the UPL conversion. We did get funding for that for the last 2 state fiscal years, but now that we're sort of taking a slightly different model with the UPL conversion for this year, we are awaiting CMS approval to go back to April 1st of 2022. Once that does get approved, that will also help with our cash position. We have our special populations proposal that John has talked about. We formally did submit our proposal to CMS at the end of December, so that was a huge step and a whole body of work by a whole lot of members of our team, so that was extremely exciting. We're waiting on their feedback, but assuming we get approval the first year, we'd focus on the single adult homeless population, so we're hoping that, as quick as we can get approval, we can start the implementation there. Behavioral health centers of excellence also is something that John's talked about and that we're working with the state closely on. We're hoping that gets implemented this state fiscal year, prior to April 1. That would be about a $150 million program statewide over 3 years. We'll see exactly what our share would be, but of course, given how critical we are in the behavioral health space, we do think we'll get a good share of that ultimately. And then, as I noted on the previous slide, we are hoping to catch up on all of our retro UPL fee-for-service payments. So the 2021 outpatient will likely come first in the next couple of weeks. And then we have the 2020 inpatient and outpatient that is, near final approval with CMS and the state. And then the 2021 inpatient as well, that we're hoping will come, in the next few weeks. Ideally by the end of, January, early February, but certainly, during the first quarter of 2023. So beyond that, can we go back? Beyond that, we are, getting into state budget season. So certainly a lot to focus on there. I think our top priorities really are avoiding cuts this year. We did get a 1% Medicaid rate increase last year. Of course, we'd always love, rate increase, but at the very least, no cuts, no going back. And there is on the 340B pharmacy side, a proposed cut that would go into effect. That was proposed a couple years back as of April 1, so we're hoping that we can, delay or eliminate that cut as well. On the third bullet, both sort of a state and a federal item related to DISH, we are hopeful to continue to delay or eliminate the federal DISH cuts that would begin as of October 1 of 2023. We have been successful doing that, several times in the past, but with the new Congress and everything, we want to make sure that that continues to be a focus, both at the federal level and if the cuts did go into effect, that we'd work with the state to mitigate them to the effect that there was an impact, but ideally we don't, get there. And at the same time, sort of a longer term, hoping to just do other advocacy around DISH to sort of support safety net systems and potentially help us, get additional funds or, potentially even a margin in terms of our DISH, down the line. Ideally we'll work towards that.
And that would require legislative change or just CMS change for the margin?
It would, federal legislation.
It would require federal legislation. Challenging. Proposition these days.
Yeah.
Certainly.
All right.
And then finally, the last one, I think Deb Brown mentioned at the Strategic Planning Committee meeting, but in the omnibus, there was some workforce flexibility continued, and I think we're pushing both at the federal level for those to continue and, in some cases be made permanent, and also the ones that are governed strictly by the state, some things that were either done through executive orders or other things during the pandemic, to continue to have some of the workforce flexibility, top of the license work for our providers and things like that, as well as telehealth parity for audio only, as well as audio and video, which we see as an equity issue for our patients, that can continue, beyond the pandemic, and that we can sort of get those funds, beyond the end of the state fiscal year.
Um, w- Sorry, any questions? Nope. Oh, Barbara?
It's really a footnote. How much data is on the web for the common person to see regarding our finance?
I think in terms of the comment, I mean, we bring our financial plan on a cash basis to the board each year. We bring that at our next meeting, and then we do publish our financial statements.
Yeah, the budgetary, I guess,
Our-
you know.
Beyond what's reported here, our budget is not put up on the web.
Not even aspects in the mayor's report.
Right, so the mayor's report includes, it's presented differently. So there's our financial plan, which is incorporated into the city's financial plan. So that's, at this point, I would say maybe once a year, sometimes twice a year, published on the city site.
Thank you.
I do have a question.
Michelle?
I was just wondering if you look at the bullets where we're looking to receive some payments and the bullets where we're looking to avoid cuts, has this been monetized at all? How does it work out in our favor?
I think that's a good question. I'll let Linda add as well. But I mean, I think from the perspective of the first bullet, those are definitely the biggest dollar figures, but it's a lot of items that we've been waiting on for a long time. So it's a lot to help meet our financial plan at the end of the day. So I wouldn't say that there's necessarily a ton of new money beyond what we've been hoping for there, but that certainly getting all the approvals would be extremely beneficial from a cash
Special
perspective.
populations be new money, or that's?
We believe it would be new money. We're still working through that proposal with the state and CMS. It'll ultimately depend on specifically what CMS approves. And we have a lot of projecting to do there in terms of what we think will happen with that population over time. I think first and foremost, that program is really an investment in improved care management and improved care outcomes for a very vulnerable, high-need population. We think over the long term, given our track record with care management and with risk arrangements, which is what this would be, we expect to see some benefit, but we're still sort of pinning down what we think it will look like.
Right, I mean, I sort of think of the first bullet, Michelle, as almost money that we already are owed, or,
I think it's a mix. So the UPL payments, the retro, definitely money that we're owed, that we have specific amounts we're expecting.
right, and the conversion's more just stabilizing as opposed to
Right.
generating new dollars, stabilizing our cash flow.
Right. Special populations and behavioral health would be newer programs. I think just given the way that our history of having to work out these types of special funding programs, they replace things that may have cycled out. So you can sort of, in that sense, they may not necessarily be new funding, but they're new programs that we're not currently budgeted to receive.
So I'm wondering, so my bottom line question is, if we don't get the money that's owed us or new money and we can't avoid the cuts, how much trouble are we in financially?
Well, we continue to manage, with the city. I think we have contingency built into our financial plan. We expect to work out the majority of these items. I think the value of them, is yet to be determined. I think with the potential risks under the state budget, we evaluate as we go. I think we've built in a little bit of cushion in our plan to anticipate that some of these things, may ultimately impact us, but we, haven't sort of, we're still fighting the good fight, I guess to say. So we have, ongoing analysis on our 5-year plan of how we're going to deal with not just these items, but, other cost pressures that we have, all of the work that we continue to need to do to maintain and improve revenues. So I think there's a balance of initiatives, and if these things come to fruition, we would have plans in place to address them within the financial plan.
But that would be not good.
Would not be good.
Yeah, I don't think this is like,
So because this weekend's, or the work that's been happening with NISNO, where the voluntaries are giving 18% salary increases, and
Right.
proving the benefits, if we have to take that on, how does that fit into our budgetary predictions? And I was just wondering, just very simplistically, is it going to be a major impact for us to meet the NISNA
We
that the
have some-
voluntaries are agreeing to?
We build in some baseline assumptions about collective bargaining increases over time in our financial plan. It may not exactly line out to what's ultimately negotiated. And we also continue to look to the city. They have been, for the past few years, funding collective bargaining for us. That's been a huge assistance to our financial plans. We would continue to have those conversations. So I think it's just always a give and take. There are many things out there that have potential to escalate cost or affect revenues, and we balance that in our discussions internally, operationally. What can we do to improve and find savings, and what do we need to discuss with the city about how we work with them to deal with our overall financial plan.
Thanks for that.
Thank you, Michelle. It's a good, I think it is, these guys do miracle work, but it's challenging. A lot of risks on the horizon, I think. Sorry, if no other questions, you can keep going.
Hi everyone, I'm going to talk about our HERC work this year. So in the beginning of October, Mayor Adams announced a state of emergency based on the arrival of thousands of individuals and families seeking asylum in New York City. Following that state of emergency, he issued an executive order 224, which ordered the opening of HERCs and tasked health and hospitals with the oversight of that work. These sites provide the following services to folks arriving to the city: basic human necessities such as food, clothing, and shelter, resettlement support and transportation to friends or family in and beyond New York City, as well as medical and social services. As you know, trends in arrivals of asylum seekers to the city remain unpredictable, so the length of the program and the size of the program remains unknown so far. Next slide. To date, or through December, we've committed $92.4 million to this work. OMB has agreed to provide H&H with sufficient revenue through an MOU with the mayor's office to cover these expenses. And today there are currently 4 sites open supporting these individuals.
How many people are residing at these 4 sites, do you know?
I don't know off the top of my head. I think it was around 7,000 last week.
Thank you.
I just remember the mayor keeps throwing out $1 billion number about dealing with the influx of immigrants. I don't know if that's a projection. I mean, so far from the 94 million, I just don't know what his number includes.
Yeah, I think that the $1 billion that the mayor has been referencing is inclusive of all the city agencies, so that would include the work that we're doing for the HERCs as well as the other agencies, so the Office of Emergency Management, Department of Social Services, and Department of Homeless Services. I believe HPD is doing a little bit of work, so that $1 billion would be a citywide effort through the entirety of fiscal
And
23.
stuff like, providing the social services and the food and clothing shelter, are we using other agencies to do that, or are we doing that ourselves?
It's a mix where you have a lot of vendors supporting that work as well as working with others in the task force.
But then the 92 million covers these services that we're managing, or there's?
Yep, it's what we've incurred so far through December for the sites that are operational through that date. So.
And medical care as well. Is this all on-site care?
Yep, we've got like health vans that are at certain sites that provide intake of folks arriving, as well as vaccines and other basic medical care as needed.
So if they're taken to a hospital, is that also counted in this? Their care once they arrive at the hospital, or no?
This is not inclusive of care in our hospitals. This is
site,
only
yeah.
at the sites or associated with the
All right,
sites.
just strictly at the site.
And when we incur the expenses, I'm trying to understand how that impacts our cash flow on the financial side. Do we get the money to cover those expenses right away, or?
Yeah, so we've been working with OMB in terms of the revenues that they have available, that they've put in their financial plan to draw the funds as we pay them out. To date, we've paid out less than we've committed, but yeah, we're continuing to work with them on an ongoing basis to ensure that it doesn't negatively impact our cash flow.
You can just show them the first page of your presentation. We can't be the float.
Exactly.
Right. Okay. Any other questions? Okay. Well, thank you very much. Any old business? Any new business? There being no further discussion, meeting adjourned. Thank you. Alicia, gave you 10 minutes.
This meeting